Good to go. Hello. A very good evening to one and all. I, Dr. Dhammadip Dabhade, on behalf of Emcure Pharmaceuticals Limited, welcome you all on the occasion of No Thrombosis live in box. No Thrombosis is the unique scientific initiative by Emcure wherein we will learn, understand, and explore the multifaceted landscape of the interventional cardiology with the help of various interesting cases on interventional cardiology. And to take this forward, we have experts with us. It's my privilege and honor to welcome and introduce course director for this meeting, Professor Dr. Prafulla Kerkar, sir. Few words about sir. Sir is the emeritus professor at SET GS Medical College and KM Hospital, and also the consultant interventional cardiologist at Asian Heart Institute, Mumbai. Sir being the former guidelines committee chairman of CSI and CSI guidance document. Sir being the chairman of Board of Studies of MUHS Maharashtra, former chairman of Pinnacle India Registry, former president of CSI Mumbai chapter, and also organizer for the CSI Con 28. Sir been the investigator of various landmarks trial like CREATE, PREDICT, and Paradigm HF, etc. Sir also been the national leader for the Paradise MI and Surmount MMO trials. And Sir had several hundred publications and presentations in national and international journals or meetings, including prestigious orations and awards. So thank you, sir, for joining for this webinar. To take it ahead, I would like to now welcome and introduce the moderators for this meeting. Our first moderator, Dr. Vidyut Jain, sir. Sir is the consultant cardiologist from Chaitram Hospital and CHL Hospital, Indore. Sir been the past national vice president of CSI, faculty in various forums like ACC, TCT, CAP, national convener for hypertension sub-council of CSI in 2016 and 18, EC member and joint secretary, Indian Academy of Echocardiography, scientific council member for Asia Pacific Society of Cardiology, serving the editorial board member of Asia Pacific Journal of Cardiology and various other journals, and been the abstract reviewer for ESC conferences, been the principal investigator for multiple landmark trials at international levels, and had several publications and book chapters in his credit. So thank you, sir, for joining with us for this meeting. I would like to welcome and introduce our next moderator for this webinar, Dr. R. Rajaram, sir. Sir is the consultant interventional cardiologist from KIMS Sunshine Hospital, Hyderabad. Sir has expertise in the complex coronary interventions, rotational atherectomy, and peripheral and structural interventions. Sir has his area of interest mainly in cheap CTO interventions and electrophysiology, and been the life member of various cardiological societies, including CSI and Indian Academy of Echocardiography. So thank you, sir, for joining to this webinar. Now, I would like to welcome and introduce our two speakers for today's meeting. Our first speaker, Dr. Kuldeep Totawar, sir, who is the interventional cardiologist from Medicover Hospital, Aurangabad. And he will be presenting in front of us a case de novo thrombus during left main PCI. I would like to welcome our next speaker for this webinar, Dr. S. Sadanandam, sir, who is the consultant interventional cardiologist from Sri Ramachandra Medical Center, Chennai. And he will be presenting with us a case on topic, give your best in crisis. So with that brief introduction of our today's faculty, I would like to read quickly the agenda for the benefit of our audience today. We'll be starting with the opening remarks from our course director, Professor Dr. Prafulla Kerkar, sir, followed by two case presentations first from Dr. Kuldeep and second from Dr. Sadanandam sir. And then we will be having discussion followed by each case amongst the course director and the moderators. And then we will end up with the concluding remarks from the course director and the formal vote of thanks. Last but not least, I would like to welcome all our audience who joined from across the India for this meeting. And I request the audience to put your questions in the comment box. And after case presentation, we will take those questions for the discussion. With that short request, I would like to stop here and would like to, without further ado, I would like to hand it over to Dr. Prafulla Kerkar sir to take this meeting forward. ओवर टू
मॉडरेटर ज्वाइन हुए आप? मॉडरेटर ज्वाइन हुए, स्पीकर नहीं ज्वाइन हुए आपके अभी तक? हाँ हाँ
यस सर, ओवर टू यू.
Hello. Yeah, somebody, organizers need to mute themselves. Yeah, okay. Thank you so much, Dr. Dabade, for those kind introductions. And let's get started without much ado. And as you heard from Dr. Dabade, what started during COVID, I think it was, what started as a no thrombosis only seminar, no pun intended, or no, the knowledge of thrombosis, as well as an attempt to eliminate thrombus, okay, by medical treatment. Of course, it was restricted to a lot of discussion. There were didactic lectures, people would give lectures, but then it has evolved into KT live, no thrombosis live. And that means that we are strictly restricting ourselves to interventional cases today, and not just thrombosis, which of course is the Achilles heel of angioplasty and real fire when you have to deal with in the cath lab. And thankfully we have one such case from Kuldeep, Dr. Kuldeep from Aurangabad. So we'll discuss that, of course. But during this KT Live seminars, we've done other areas of interventional cardiology, not only dealing with thrombus, but bifurcation lesions. We've done calcium chelating, calcium modifying techniques, etc. So today's seminar is actually theme-wise devoted to the radial access for ACS interventions. Okay, that was the theme actually. But I don't know, unless you have recently done something, meaning we could also have discussions. We have eminent faculty, Dr. Vidyut Jain, Dr. Rajaram as well. And you've got such upcoming dynamic angioplasters here, I mean, dynamic young cardiologists who, so what would be the preferred approach? As we all know, and I suppose even the audience might know that we, as a recommendation, radial route is given a class 1 recommendation for primary PCI as well, and PCI during interventions. But how often do we do that as a class 1 recommendation? Having said that, it has got obviously why the class 1 recommendation. We all know radial route otherwise is a very preferred access just to please our, and for the customer satisfaction, so to say, the patient satisfaction. And of course, the greatest advantage is that the patient is up and about, mobile early, shorter hospital stays. But the greatest advantage is the bleeding business, yeah, major bleeding. And not only I'm talking in the real world scenario, but also in trial scenarios where properly conducted trials, we've got a lot of those. Matrix is one such trial, Rival is another trial, then you've got Rifle, STIAX, etc. So that means less bleeding, definitely so, compared to the femoral access. And that translates also in certain subgroup analysis, especially the primary PCI scenario, decreasing mortality. So that's the reason why it gets a class 1 recommendation. And let's see as to, I suppose Dr. Kuldeep is also going to present one such thing. Now, on top of that, not only a radial intervention during ACS, as we all know, that we could have thrombus sitting there as well, right? And he is going to deal with de novo thrombosis that has occurred in not only the worst area that you can think about, the left main itself. And obviously, he's going to discuss that in details as to how and nuances of it. And then we'll have Dr. Vidyut Jain and Dr. Rajaram discussing that further. So let's get started with these opening remarks. I welcome all delegates who have logged in there, and they would put in, as Dr. Dabade mentioned, questions in the chat box. And let's get started. Over to you, Dr. Kuldeep. Or if you want to, Dr. Rajaram and Dr. Vidyut could put in some words, or we could do it after the case. So let's get started with the case presentation right away. Yep.
That will be better, sir.
Good evening, sir. Good evening, Kerkar sir, Jayan sir, and Rajaram sir. Sir, I am Kerkar sir. I am an alumnus of KM Hospital. So
Oh,
you have
now,
been my
wow.
teacher during my
Welcome.
UG and PG days. So it's truly an honor, sir, to present before you.
Nice.
I'll start my case, sir. I'll share the screen.
Minimize,
Kuldeep, you just
yes. You can
minimize
minimize,
this.
yes, yes.
Yeah,
Correct,
that's
correct.
better. Lovely. And now go to the
I'm not
slideshow.
able to see you, sir. That's why I thought. Okay.
Yeah, that's
Uh,
okay. You can
I'll
get started. So long as you get the
Can
on
Mac
okay,
screen,
okay, sir. I'll
go
start,
onto a
sir.
slide. Yeah, get onto a slideshow. We are seeing your, that's better.
perfect.
Yeah, perfect. We can see everything. You may not see us, but we can see you and you can go
Okay,
ahead
sir.
and do it. Good. Thanks.
Sure, sure, sir. Yes.
We'll mute ourselves.
First of all, thank you, Emcure, for giving me this opportunity to present this case. So I will be starting with my case. So patient was a 72-year-old male. He was a known hypertensive on regular treatment since 10 years, and he had visited Apollo Hyderabad for complaints of chest heaviness on exertion, which was of recent onset with 2 to 3 months of duration. And there he underwent a primary evaluation where ECG was okay, well within normal limits, and ECOG was also, except mild concentric elevation, there was no any remarkable finding. Treadmill test was strongly positive with 2 horizontal ST depressions, which were persisting into early and late recovery at 6 months. His lab investigations were okay. Hemoglobin was 13.4. Renal function tests were within normal limits. He was subjected for angiography in view of strongly positive TMT there, and the angiogram was done there. As we can appreciate in the LO view, there is eccentric 50 to 60% stenosis in the left main at the left main ostium, and LAD also we can appreciate that there in the proximal LAD. In the areocaudal view, in the proximal LAD, there is some moderate disease and it appears calcified also. This was the epicranial view. Here also we can appreciate that there is subtle focal 70 to 80% stenosis in the mid LAD, and the rest of the vessel was normal. L6 was dominant and RCA was non-dominant vessel with no obstructive disease. So the patient had come to us with crescendo angina of class 2, which had progressed over 2 to 3 months of duration to class 3, and TMT was positive. Syntax score was around 24, and so we had planned after a discussion with the patient and the relatives, we had planned for an IVAS guided left main and LED PCI with debulking strategy after the imaging. So we went ahead with wiring both the vessels, and then we took a IVAS run, and this was actually run from the proximal LAD. So there was around 170 degree of calcium arc, superficial and deep both in the proximal LAD. And then distal LED also, distal LM also had calcification, but there was a fair enough landing zone in the shaft of the LM, and the ostial left main also appeared to be the area was significantly less. The area at the minimum lumen area at the left main ostium was 5.1 millimeter square. Distal left main, there was a landing zone in the distal left main. It was there was some plaque burden, but not so significant. And the ostium of the LAD was also relatively free of disease. So we went ahead with the pre-dilatation of the mid-LED lesion Medullary lesion was dilated with 2.5 into 15 at 16 atmospheres. And as a routine, we just took a shoot because patient was complaining chest pain. So in the cranial view, we didn't appreciate much, but in the caudal view, here we can see that there is a filling defect at the distal left main and the ostium of the circ. Yeah. Here, actually, this we just started the case and we had done only IVUS, and after mid-LED pre-dilatation, we had this thrombus. ACT was also done, which was fair enough, 290 milliseconds, and but because patient was having chest pain, we went ahead with directly with the thrombus aspiration as the initial choice now, and then we took multiple runs into LCX first initially, and after L6, in the next shoot, we saw that there is some thrombus which has gone into diagonal branch, but it was not occluding, not obstructing the flow of the diagonal. Then we took thrombus aspiration runs into LED also, because there was some thrombus in the mid LED also. And this was the shoot after the thrombus aspiration. Here we can appreciate that the thrombus has embolized from the, or maybe we were partially successful at aspirating it, and some had embolized to the OM and diagonal branch. The diagonal here, we can appreciate that the flow is not good. Then we went ahead with stenting of the LED lesion. There was a proximal to mid long lesion, so we went ahead with the 275 into 48 expedition according to distal reference size. And this was immediate shoot after the stenting. The post dilatation was also done with 3.5 in the proximal segment and 3 in the mid segment. Then we went ahead with the ostial Wolverine cutting balloon inflation at the ostium of the left main. We had 3 into 15 Wolverine available at our shelf. So we went ahead with 3 into 15 cutting balloon. And then stenting was done with 4 into 12 alpine at left main ostium. This was the result after the stenting. Here, diagonal, we didn't do much. We just gave GP2B inhibitors and vasodilators, and the flow was good. Still, there was some thrombus in the diagonal, but patient was relatively free of pain, and ECG had settled. L6 appeared okay. This is the cranial view. This was the post-IVUS run. So here the stent was well opposed and expanded. The MSAs were quite improved after the post dilatation with 3 and 3.5 in the LED stent, and left main stent was post dilated with 4.5 and played with the same balloon 4.5 into 10 NC. The area at the ostium of the left main was 14.4 millimeters of square. So we had covered the ostium. So this was a surprise to us because it was just at the start of the procedure. We didn't expect that the thrombus would appear so early. There could be the one reason we could think of is that we used aux wires there because there were some issues with the financial restraints also. But although any case where intracoronary thrombus is there, the most common causes are either inadequate anticoagulation, vessel injury because of balloon dilatation, or it could be hardware related, which we thought it in our case. or it is a catheter thrombus which got embolized when we were exchanging the heart race. So the best treatment for is to prevent it from occurring. And what in our case we did thrombus aspiration. Penumbra was not available at that time, and so we didn't go ahead. But it is also a good option. And or otherwise we can crush the thrombus with repeated low balloon inflation and give intracoronary vasodilators and platelets. And then the last option is to go ahead with stenting. Thank you, sir.
Well, that's an excellent bailout that you've done, but obviously you could not figure out, despite the fact that you had imaging, because you'd already stented it. So the injury you could
Yes,
not obviously make out an injury related, whether there was a thrombus that formed and that went and lodged at the bifurcation. That is one thing, or whether you, whilst wiring the circ itself, but that was even before that you got it, right? You just balloon dilated only
yes,
distally.
sir. Just we wired
Proximally.
initially both the vessels and then balloon dilated the mid LA lesion. That's it.
Right. So with just that mid-LED lesion balloon, this thing that you did, I don't know where the thrombus came from, unless it was a guide catheter-induced injury and that caused it. That's one thing that one can think about also. And of course, one thing as far as Oxford usage is concerned, there was ever since when in good old days when we were just doing POBAs also, the only thing that to not reuse was, at least as a teaching, used to tell people also, and we ourselves also used to follow it strictly, was never to reuse guide wires. Rest of it is all still fine, but fine because of economic constraints. But guide wire cost saving is something that is not great. So I think that guide wires should be, that is my thing at
Yes.
least. And let me hand it over first to the moderators, Dr. Rajaram and Dr. Vidyut Jain first, and then Dr. Rajaram. You have any questions and any thoughts as to how, whether it could have been tackled differently? Or only one question that I have at this stage is that when you had, of course, ST elevations, possibly you had chest pain going on, you got an
Yes.
ominous thrombus sitting at the bifurcation, and also there's some thrombus at the diagonal level, also, as you
Yes.
mentioned. Did you ever think that if we might require a need to have a separate access, one more access for a intra-aortic balloon pump? So for instance, if you were radial here, that was the theme of
Yes,
the
sir.
meeting. If you were radial and say you had decided to do an ad hoc PCI on him, or that you had taken him up for an ACS scenario with a radial route, at least that's one thing that I would first think about as soon as you see left
Yes,
main
sir. Yes.
thrombus, that if God forbid, if something were to happen, then all said and done, all the trials, be it, we do not have impellers and stuff like that with us, but at least an intra-aortic balloon pump access should be in place, is what I would say. So that's the first. And of course, this colleague could go take that punctures while you are aspirating, doing everything.
Correct. Correct. Yes, sir. Yes.
So, because he doesn't give you much time
But
then after that.
yes, sir.
Yeah,
And we were
Dr.
actually lucky enough, sir, that immediately with the thrombus aspiration run, actually maybe with our thrombus aspiration catheter, it got pushed below, or it got embolized below, and then with some runs into both L6 and LAD, it got disappeared from the that bifurcation. So we
Exactly.
were happy
That
with
was
that.
a lucky thing that you didn't have to do
Yes,
anything across the circ. And
yes,
one more thing I was going to ask you is, did you manage to get any stuff in the fresh thrombus or something in the aspiration catheter afterwards when you injected into the gauze piece or something?
uh,
Get
not
anything?
much, sir.
Not
There
much.
was
It was
some, but
just
not
dottering.
significant, sir. Yeah.
You mean it was just dottering of the thrombus?
Dottering, yes, sir. Maybe. I mean,
Okay.
we did dottering and aspiration, but it eventually turned out to be only dottering because we couldn't aspirate much in the
Okay.
this.
That's
Yeah.
good. Yeah. Nice to present that. Dr. Vidyut Jain and Dr. Rajaram,
Yeah,
please. Yeah.
I would like to just congratulate him first for immediate recognition of the problem, which is often missed. That's
Yes.
first thing. Then he managed it well. But I was just wondering, the clot was, a thrombus was so rapidly occurring. Could an intracoronary thrombolytic would have helped him? Because this patient had a thrombus within minutes. It is not a late thrombus or something like that. So that can be sometime tackled if you don't have a lot of facility. And second thing, as you pointed out, at the same time, you should have femoral approach ready for any catastrophe like intra-aortic balloon pump needed. These are the two
Yes, sir.
things. And third thing, he possibly had to use the cutting balloon in the left main, correct? That's what you
Yes, sir.
told? Yeah.
Yes, sir.
Was calcium management or it
Yes,
was
sir.
fiber?
And it was fibrotic also, and
Yeah.
not so calcified, the left main osteum, but it was
Yeah.
more of fibrotic lesion and the osteum of the out osteal lesion. So we painted with
Anyway, so first we congratulate you for having good result and coming out of the whatever problem you faced. So immediately, if one can use intracranial thrombolytics or not?
In this case, I was not sure, sir, because the presentation was actually chronic, like progressive angina.
Yeah.
He was a stable ischemic heart disease, maybe you can
But
say, and
thrombus was
LV function was
very,
normal.
very fast. It has occurred within minutes of your
Yes.
procedure.
I don't think that is recommended generally. The best thing is to aspirate it out and then use little balloons to crush it and then
Crush
go
it.
ahead and stent it when you do not know the mechanism itself. Though a lot of people say with a thrombus there, you put a stent, it is a this thing. But stenting, what it does is that it gets the lumen flushes out, meaning the flow gets established immediately with stenting. So it was wise to have taken that long stent and then taken a second stent.
Yes.
But one must accept that it was almost a dominant circ, right? And your
Yes,
wire was
yes.
into the OM, the upper OM, but this continuation also was fairly because the right was non-dominant. Dr.
Yes.
Rajaram, some views from you, sir. You are unmute yourself, please. Unmute yourself.
Good evening, sir. Am I audible, sir?
Yes, very well. Go
Yeah,
ahead.
thank you. So, good evening, everyone. That was a nice case presented today, and this is an often encountered complication, sir. Now and then, suppose if you are going for the primary PTCS and all those things. So, this kind of around 90 to 180-degree calcification in the LMCA, bifurcation lesions, and then when you just predilate it, immediately the thrombus may shift to circ and all those things. So one thing is most probably it is thrombus only, but sometimes there is a shift of the plaque may also takes place. So as you said immediately, so there are two or three issues. One thing is whether they have patient was adequately duration of antiplatelets was given or not for this patient, we don't know. Suppose if that kind of situation is there, immediately I would have opted for the cangrelor IV
I
infusion,
was about
so
to,
that to
yeah, I
make
was
sure
about
that
to
the
ask that.
proper antiplatelet action. At
This
least
was a planned case, sir. So we had given Axer like
so
day
you
before.
have given adequate time for this.
Loading. Yes, yes.
So that is the first thing. Second thing is as soon as you recognize that there is an LMCA and you are going to address the LMCA, nothing wrong in going with the radial. You can as well go for it. But as sir told that you should be ready in case if there is any this kind of situations develop. Sometimes the patient may not give that much of time. The patient immediately develops BP low and all those things. So you should be ready for femoral arterial access and then do some kind of IABP support and all those things if necessary. So mentally you should be ready. Mentally you should be ready. And the second thing is this kind of small thrombus shifts here and there, even if you do primary PTCS to either LAD or whatever it may be, the shiftings will take place to the side branches. And here it doesn't look like a severe one. It is a hardly 1.5 times of the vessel diameter. So I don't consider it as a severe thrombus, but certainly there is a thrombus which is occluding the circ ostium. So you should have, first of all, there is a daughtering is the first thing. Put it, just do the daughtering and then you can do some GP2B3A inhibitors and all those things. And then you can give some vasodilators and then check whether you could get any flow or not. So instead of doing all these measures. So I would have done with a simple daughtering and followed by mild, take a small balloons like 1.5 or 2 mm balloons and then dilate it if necessary to break that thrombus. And then you can give some vasodilators and then see if you could get any flow or not. If that thrombus is extending to the LMCA, then only I would have gone for the thrombus extraction. Otherwise, this thrombus extraction is a class 3 indication because it has got very high incidence of strokes and all those things. Even the latest guidelines also deny. But exceptional cases like very large thrombus occupying left main and patient is hemodynamically unstable, in those cases, to establish some flow, sometimes you may not get any flow in spite of adequate dilatations and all those things, you may not get that much of flow. In those cases, you can try this thrombus aspiration if it is a fresh thrombus. That is again. So another option which comes to my mind, suppose if you doesn't clear that thrombus, then usually we may opt for this laser therapy. ELCA also you can try. So sometimes with the ELCA, you can modify this thrombus and then this plaque, and then followed by, if you could establish some flow, then you can do your routine this thing. So those are all my inputs to deal with the thrombus. But anyhow, it was nicely done, even with the sorry. So even if you do some thrombus extraction, I often find that there is not much use, even by using the thrombus extraction also. A couple of times I have used this thrombus extraction catheter, but it was not of that much of help. But instead, these routine measures like pulverization or thrombus vasodilators or GP2B3A, or we have used 2 times this ELCA also. That was also giving a good result. So those are all the things, and ultimately it was a good result. So I think I must congratulate you.
Congratulations, Dr. Kuldeep. Since you alluded to ELCA, you did say that the plan was calcium modification. So, what was your plan for calcium modification? Say this had not happened. You just did a cutting balloon on the ostium, but otherwise, what were you planning? Were you planning IVL and stuff like that, or the cutting balloon was the only calcium modification that
No,
you had
sir.
thought?
Yes, sir. Cutting balloon was available only, and because angiographically it looked like it was a moderately calcified vessel, but once
Yeah.
the imaging was done, there was some arc in the proximal to mid, but not more than 180-degree arc. So we had done even cutting balloon there also with the 275 cutting balloon, and ostium was done with the NY Wolverine 3 into 15.
Okay. Okay. So that's what. So the thing is, recent trials did put IVL into not really the high pedestal anymore. Yeah. Meaning cutting balloons and these are as good. There was some trial at the recent TCT meeting which showed I didn't put IVL into, didn't give a success to IVL in a big way. Similar results. I don't forget the name of the trial. That was there anyway. Anyway, so let's move on to the next case. Thank you, Dr. Rajaram and Dr. Jain and Dr. Kuldeep, and obviously we might have something coming out in the chat box also to answer later. But I shall now call upon Dr. Sadanandam to present his case. Yeah, can you
Yeah,
share the
thank you.
screen? Get started.
Yeah. So, good evening, everybody. I'm Dr. Sadanandam, Professor of Cardiology from Sri Ramchandra University, Chennai. My topic, as per the Dr. somebody called from, they told about presenting of a STEMI. That's what the topic given to me. So, I'm going to present a topic on STEMI only. Here is a 59-year-old man, diabetic, presented with antral MI, and he had a moderate LV dysfunction. Unfortunately, he had an hypotension during the presentation itself. So we have to consider this cardiogenic shock, not responding to any inotropes. So we have to go with directly with the femoral access only. So this was done, and you can see here the dominant circumflex filling, and there is a large chunk of thrombus occupying the proximal LAD with the trickling of blood or dye into the mid LAD. You can see he was in shock, so we are trying to stabilize him with inotropes, and you can see the dominant circ filling well, and LAD was flowing almost a TIMI off or TIMI 1 flow, but not reaching the. These are the thrombus thing which we observed here. So initially there was a flow, but you can see there is a plaque in the left main also, distal left main also. There is a plaque, and there is a quite a typical classical angulation arising of the ostial LAD into the showing a thrombus, and slowly it was being done, and multiple angles are taken. RCA doesn't have any much disease. Here I will show one shot. there is a mild disease in the small branches of RV, and we have to go with IABP support for controlling the thing. There was a difficulty in negotiating the wire, so I went anyhow because of Levman disease and the dominance of the circumflex. Always I try to have a supportive wire in the circumflex in case if you need to do a final kissing balloon, we need if there is a block shift in the circumflex, dominant circumflex, that time I should not struggle. That's why, yeah, generally we make it as a policy to put a wire the circumflex in case of even in the time of emergency also. You can see I am trying to negotiate the wire across the angulated segment with the normal workhorse wires like run through and whisper wire, which we are not able to cross. So multiple attempts has been done, but it is going either to the earlier OM or ramus intermediates, whatever you call it. It was going to those small branches only, but we are not able to enter that thing. Though I am able to catch up the ostium of the LED, it was not able to think. We can see the IABP being operated meanwhile from the other axis of the femoral artery. Finally, we have to take a fielder XT wire because fielder XT wire is a wire which slides into small places also. It's a CTO wire, but generally, whenever we don't have results through fielder in other ways like whisper or workhorse wire like run through, I prefer to take a fielder XT wire so that it slides just like that, and because of its like hydrophilic nature. And so this one we have crossed the lesion, and again we were thinking whether should we go for thrombosection or should we go for ballooning, I mean daughtering of the vessels. And because of the dominance of the circ, we have previously lot of operators have faced spillage of the thrombus into the circumflex, which was a undiseased segment in the undiseased segment. So we decided to directly dilate the ostial LED after daughtering. So we started dilating the ostial LED, and now we are able to establish some sort of a TME2 flow in the distal LED with the branches like septal and diagonal branches started filling. And you can see here repeated dilatation was done to establish a good support. Though the angle of LED in circumflex is around 90°, we made sure that there is no, we are very careful in dilating the ostial LED, pushing always the balloon distally after dilatation also, so that even some micro shower of emboli can be avoided into the circumflex. And if we took a cranial shot where it was showing the diseased segment in the LED ostium also, though RU caudal doesn't show anything, but in cranial view, if you see, there are diseased segment in the left main ostium also. So this was taken for assessing where the stent should be placed. So multiple segments, multiple shots were taken, and we decided to go ahead with the stunting of from the ostium level, because in the middle of the body, we don't know where to stop, and there was some suspicion of ostial involvement of the left main also. So we kept 1 or 2 steps away from the ostium, positioned it exactly in the left main, and started deflating with a single stent strategy. I went across crossed across the carina into the left main. A single stent was used, and there is no diseased mouth of the ostium of the circumflex, as well as there is no spillage of the thrombus or plaque shift was there. Hence, we went across the left main to LED, and after checking a shot, then circumflex wire was inflation. Circumflex wire was nicely withdrawn without any hindrance. And again, repeated dilatation was done in the left main to LED decision. Though we know part is very important, but because the same balloon has been used and it is an emergency, I went ahead with a repeated dilatation with the same balloon, then post-dilated with the smaller balloons after doing a part also. You can see the IVUS run here. IVUS shows a now only it's going to start a well expanded stent, a well opposed stent also. And when it comes to the left main, you can see yeah, it's now the stent is well opposed. And one thing is, when we come into the ostial LED as well as in the left main disease, the plaque burden was still more than 30%. So that was the thing, and so we went ahead again with the repot technique. That is, again we went again with the 4 into 8 millimeter balloon at a higher atmospheric pressure, like 16, as per the IVAS calculation of the left main diameter. And then finally we took repeatedly we flared up at the ostium also, and you can see the final shots being taken now. Yeah, sorry, final shots. We have a good result. At least TIMI 2.5 flow has been obtained distally, and diurnal and septal branches are flowing well. And next day we removed you can see a well expanded left main to LED stent, typically showing a broad left main with LED also, expanded LED segment stents. And it's a good result for the patient is fine now. And next day IABP was removed, and patient was discharged safely. Thank you.
Well, Dr. Sadanand, that's an excellent case. And actually, it points out to a little bit of a discussion we had with Dr. Kuldeep also about keeping an access for the IBP. And in your case, you were radial by approach,
Yeah.
but then you went, why did you choose to do the angioplasty also through the femoral?
Yeah, because sometimes, see, we need a sound French.
You had two femoral accesses.
Yeah, two femoral access. One is for IABP, another one is for sound French. Radial, I'm not comfortable with sound French. So, though a lot of people are doing with sound French also, and spasm and other things, the caliber of radial is not though so good. It's a dominant circumflex. So I want to keep things prepared in case there is a clock shift. I have to use two stents strategy. Means sound French catheter is better than a 6 French approach.
Okay, fair enough. So
Slender
you
sheath,
had,
yeah, slender sheath is there. I agree, but why you want to struggle?
why did you went radial, right? So
Yeah.
you went radial
Yeah,
for
yeah.
a diagnostic
Diagnostic.
in a primary PCI scenario. So I'm asking you as to what was your antiplatelet regime on board, and meaning why did you go radial? You expected in a shock situation what kind of a disease? Okay,
No,
by the
ECG and echo
itself, you
showed
could
ECG and echo showed mid-segment involvement, mid LED, I mean, mid-septum, mid-antral involvement. So we were thinking that some sort of proximal or mid-LED involvement. After checking the angio, we was very shocked to see involvement of the ostial LED complete occlusion with the extension of plaque into the left main also.
Okay, so now as this thing, you spent some time. Of course, you must have kept the metrics going about your what is important to understand during radial also is the fact that the radial axis itself, from going to being able to perform a PCI through the radial itself. But by and large, you would have done the PCI itself also through the radial in this situation.
Generally,
Because it turned out to be a left main bifurcation, I agree that
yeah,
a
sound
circumference
say
axis.
the only thing which made me to switch over to is sound French catheter. Slender sheath sometimes it may not be adequately enough for the radial artery, especially for Indian women. And in case sound French, we need a left dominant system. I'm very careful. If needed, means we have to take two stents to do a final bifurcation. So sound French catheter is more. I'm very comfortable with radial. I mean, femoral than the radial.
So the wiring wise, again, you chose to wire the circumflex first. Your culprit is the LAD, right?
Yes, yes,
Of
yes.
course, it's a left main scenario. So why spend time on wearing? Could it be that your circumflex wire wasn't coming in the way of you getting into a little upward takeoff of
I
the
think
LAD?
I showed the angulation arising of LED.
Yeah.
It's a typical angulated S bend was there. So wire was not going into the LED. Whichever wire went,
Yeah.
that S bend is very difficult to negotiate. I have to keep on changing the wires from run through to whisper, then to filter XT. So meanwhile, one wire, why to take that wire? I passed into the circumflex and parked it to keep us protected.
Okay, but it was not primarily you tried to wire the what I'm trying to impress
Yeah,
upon the
everybody
audience as well.
will first try
I
to
would
wire
rather
the
go to
culprit.
First wire the culprit.
Culprit, yeah,
That's
everybody wants to wire the
and
culprit.
just a little balloon dilatation gave you all the flow. Gone was the thrombus. A flow, there is nothing better as a thrombolytic, a
Yeah.
flow, rather than giving any medications or even that's why aspiration catheters and all. What looks so ominous when you first take the first shot, you do the proximal most dilatation with a small balloon and you get a flow going, and that's what it was. Just to
But
make
wire
a
was
point.
not even going, no, sir. It was
Yeah,
yes,
yeah, it wasn't
it was
going. I
yeah.
was only wondering, of course, you tried.
Right,
I'm
yeah.
just trying to give a message that you tried LED
Yeah,
first and
tried.
going, you put it down the circ. But I was only wondering whether it would come in the way, the circ wire itself, to get into the LED, some bias going towards there. Yeah, that's a great thing. What have you shown? You planned it well. You had a two femoral accesses. So your decision to switch over, crossover from radial to this, and a crossover occurs during primary PCI scenario at least 5 to 10% of the time, and that you should do. I remember in one of the meetings, a young bloke presented. In fact, he was from KEM in the past, and he was in the periphery, and he managed to do a primary PCI of an anomalous right coming from the, or rather an anomalous coming from the right. He was not able to do it, or something to that effect. Okay, I don't remember what the anomaly was, but he struggled a lot, and then he didn't go to femoral, and he just finished with that. All that I asked him was what was your door to balloon time? So that's what is important. We shouldn't
Yeah.
lose. We should give up the persistence to want to do radial access and be willing to cross over to femoral. That's the message that it should be there. Yes, higher the volume that you've done, the better the radial operator that you are, you will stick and finish the angioplasty. So, Dr. Sadanand, at your place, it is primary PCIs are done more often than not through radial. Is it what it
No, no,
is?
the 90, our rate is 99.99%. It is only radial, sir.
Great.
Very rarely, like cardiogenic shock or something which we are not able to have some difficulties, then we switch over to femoral.
In that you're from a big
Almost
high
in last
volume.
10 years, we are doing radial only. Last
Yes,
10 years.
that's what is important. So very often in this case, it was wise to have gone over it from the femoral. But otherwise, what is happening is that people end up doing angiograms to the radial and then they're doing PCIs to the femoral. That doesn't serve the purpose. Yeah. Here there was a valid reason to shift. And what you say that you choose radial access, it has got its own benefit. Before you joined, also we were discussing the benefits of a radial access PCI versus this thing. It's as safe, or in fact, bleeding wise better, access site complications wise better, and in certain trials also translated into mortality reduction as well. And that's why it gets a class 1 indication to do a radial PCI for primary PCI. So, Dr. Rajaram, you have something to
Yeah,
say about,
I
and
have
Dr.
a suggestion,
Vidyut
sir.
Jain.
In this case, suppose I would have done like this. Suppose if you are facing any difficulty in wiring, because that is angulation is very acute angle. That LED ostium is a very acute angle. So second thing is there might be some fibrous or fibrofatty lesion or some calcium nodule might be there at the ostium. In those cases, we face lot of difficulties. Sometimes it is not possible to enter. Luckily, he has entered. But usually what I do is I'll go with the micro catheters. One is super cross. You can take a super cross because it has got an angulation. You can easily go into that situation. So one is taking up the supercross. Suppose if you don't have the supercross, any other dual lumen catheter you can try because already your circ wire is there. Already your circ wire is there. So over that you can pass your dual lumen catheter and then you can negotiate your other wires. So that is one suggestion which will make you your radiation and the time a little bit lesser.
Double lumen catheters, what is the thing is if the bifurcation is very adjacent, might be you are telling that your choice of catheter will be good. Here you can see a wide angle and the circumflex goes exactly down and the LED goes exactly upwards. The bifurcation point is so wide that I don't know, even the dual lumen catheters may help.
No, you will make the tip bend, no sir. Suppose if you make an acute bend at your wire, after once it comes out of the lumen, it will take its own shape. So you can try that. So those
Yeah,
are the two
always dual
suggestions.
lumen catheters are good, but whether this will work for this type of broad, wide division of bifurcations.
You can.
We would have tried. Yeah, it's a good
Yeah.
option.
So these are the two things which comes to my mind. Suppose if you don't, suppose if in spite of that, if you don't enter, what are your chances, sir, in this case?
Prayers only.
Yeah, no,
Retrograde.
the
Yeah.
thing
So
is that
retrograde also you can try.
no,
So
the other
suppose
thing
if you
is
are
that
confident,
what
suppose if you are confident, if you have tried once or twice, you can try through the right coronary artery and then you can do the retrograde, because that is an ambiguous gap. Sometimes we may have this kind of situation, because if it is severely calcified, severely fibrotic, elderly, 80 years old male, sometimes we feel we face lot of difficulties. Though patient comes in acute MI, you can have a try there, but these two things, most of the times, 99% of the times, suppose if you take either supercross microcatheter or some kind of dual lumen catheter,
Stingray, yeah.
so those that will help you in crossing that lesions.
so very often to wire that LAD, you need the guide catheter going little inwards, right? A shorter curve. You might want to face towards LAD
Yeah,
better. The circumflex wire would actually come in the way of your wire, the LAD wire going upwards into the LAD, right? The circumflex wire already wired, therefore it could become difficult also because the way your guide catheter would face. It wouldn't face the LAD. You wouldn't get the
Hey,
chance to put the guide catheter inside.
I did what that you bend into the focusing into the LED. See, there was a block from left main and causing a acute directing the wire in downwards. The block starts from the left main itself. It was like this. So
Okay.
whatever wire goes, the block pushes the wire down. So I
Okay.
have to makes lot of bends in the tip of the wire, and filter XT it
So
slided.
eventually, I think I personally feel the wiring of such an LED would be better without a circumflex wire in place. That's the
Yeah,
point I'm trying to make.
I
Your guide
understand.
catheter would never ever face the way you want it for the LED. That's what I'm saying. Even otherwise, usual LED wiring, if you take a smaller loop, that is going to face little inwards, right? And point towards LED. You've got a bigger loop outside, then you're going to bigger curve. That's going to point to the circ. You understand? That's what I'm just making that point. Yeah.
Another two
Yes,
suggestions, sir. I want to,
excellent. Dr.
because
Vidyut Jain is
yeah,
waiting
sir,
patiently.
I want to make another. See, while deploying the stent, you have taken out the circ wire. What was the reason, sir, before that?
No,
Why
I'm
did
not
you
able
take
to
out that
understand.
circ wire before deploying the stent?
No, I deployed stent and make sure there is the lumen was not compromised circumflex. Then for
And then
second
he pulled
repeated,
out the wire.
then I pulled out the wire for repeated dilatation. I
Yeah.
made sure that there is a no block shift in the after deployment. There is no block shift.
After
If
putting
there
the
is block
pot
shift, then
balloon,
I would
so
have
once you are
recrossed.
ready with the pot balloon in the stent, then it will be ideal to take out the circ wire. So that will one thing is that will give some stability
Yes, yes,
for putting
definitely.
your
If there
balloon,
is
and
some
then it
sort
will
of
act as
1%
a
of doubt,
marker for you where the exact carina is and all those things. So after that, once you position your pot balloon, then it is better to take out. So that was
well
one
taken.
suggestion.
Fine.
Another thing is, I think there was some significant block below the stent also in the LAD. So
LED,
that
yeah.
was causing some TB1 flow in the LAD. So I think you should have gone for another stenting distal to the stent, because there was a tight stenosis distal to the lesion, which was fibropathy plaque on IVUS. And also this final injection is also showing some decreased flow, TME2 flow or something like that, or TME1 flow sometimes. So I don't know. I think I should have gone for another one more stent distally if necessary. So those are the 2 points I want to.
Yeah, Dr. Vidyut Jain, you have to make some
Well,
comments.
many technical points have been discussed in detail. My one curiosity over here, that's now the new stent which is known as Sky Point, which you can dilate in left main up to 5 millimeter and LED, because then there's a availability of this particular stent, and left main to LED, you can have differential lumen dilatation, and that will not be mismatch or something like that. So, what is your experience regarding that in left main to LED stent? Would you use sometime Sky Point?
Yeah, we are using SkyPoint for last 1 week. We are using SkyPoint.
Yeah.
Actually, Megatron and Onyx is known for all these things. Now, Abbott has come with a new product, so just mimicking this Megatron or whatever Onyx stent. All Abbott was not having this type of 5.5 dilatation stents. Now they
Yeah.
have come with it. But already other companies like Boston Scientific and this one, Medtronic, are having stents which can expand up to 5.5.
Yeah,
Yeah.
3.5 can go up to 5.75. That is what
Yeah,
they
5.7 up to 5.75.
5.75.
Agreed, agreed,
Usually that should be adequate for our Indian.
agreed, agreed.
That eventuality.
So that has been very exciting that you have to be dealing with such a radial route, then switching over to this thing. Now, Dr. Rajaram mentioned,
One
sorry, Dr.
advantage nowadays we have is ultrasound guidance. Previously, we used to
Exactly.
keep our ultrasound guidance has reduced the number of bleeding complications.
Absolutely, it has. You mean the USG guidance for femoral punctures you're talking
Yes,
about?
yes,
Yeah.
yes.
Yeah.
Yeah, so that is what it is. Because we have all become TAVI guys now, large bore accesses. So USG guidance is, or otherwise, if we do not have a benefit of audience, I can say there are some of us who believe in just using a micro puncture basically and doing the puncture, because we always stick anterior to single puncture. We do that, but and then do a just to see the bifurcation, it becomes very important in a large bore access, isn't it? So with a micro catheter itself, with a micro puncture needle and the micro sheath itself, do an angiogram and look that you are above the you are well away from the bifurcation. Then you are good to even go ahead and need not require it for people who don't have it. For instance, let's ask of Dr. Kuldeep, because you mentioned finances. What is your access preference when you do a femoral, or even for that matter radial? Do you guys ever use USG guidance?
No, sir. Actually, UAG guidance, obviously, when we are planning for large bore access, we do use. But generally, routinely, most of even at our center, most of the pieces are done through radial only. Even in this case, I thought I would have gone with radial only because I had access already, and to save the time, because UAG guidance again will take time to check crossover. It takes times to decrease that dual to balloon time. I would have gone with radial only because there was no anatomy disturbance in the subclavian or innominate, so we can go ahead with radial angioplasty itself. Femoral UAG guidance we use only for the large bore accesses, like if you are using 8 French or more than 8 French,
What
but not
Dr.
routinely.
Sadanand, I believe, is making a point is that you routinely do a USG guidance, then you don't take time in the lab. You
Yeah,
understand? So
Exactly.
it's like, yeah, if you get
True.
used to doing it, it's just like the radial way, right? The volume of cases matters, and you can potentially increase the volume of your cases of wanting to do large bore subsequently by almost always doing a USG guidance. It's very hard, at least for us old school guys. I don't know what Dr. Vidyut Jain does, but I am like so comfortable with the femoral, and
Yeah.
the
Because
youngsters come and they want to
we
do a
start,
USG
uh,
guidance,
we,
and
we started this femoral in our career. So we feel it is always fast to do for ourselves. But as you mentioned, large bore entry and the trauma is also equally important.
exactly. So we must make it a habit. We need to change from our resistance to use what you call a USG guidance when it's available. You should almost always do that. Helps you to, subsequently get to the large bore accesses, right? And prevent groin complications, and then be in competition with the radialists to say that my femoral complications aren't much. Yeah, right. So that's how it is. So I suppose we are come to the
uh,
end of it all. Are there
I
any
am
questions?
I am a railway man, so always we used to do in femoral. After shifting to Ramchandra last 10 years, I almost stick to radial. And now back to femoral. I felt, see, initially when my juniors are doing ultrasound, I felt these people are jobless for just doing. But definitely, as sir said, you have to unlearn and relearn ultrasound guided femoral access so that you will make it fast in terms of emergency one. Second thing is nowadays TAVI and structural has grown up like anything. People come and ask for TAVI rather than we pushing for TAVI. They come and ask, I don't want a scar or I don't want a thing, I want TAVI only. So those type of patients are coming nowadays. So and definitely ultrasound guidance is very, very
Very, very
useful.
important.
Yeah, yeah.
Very important. We must make it a practice. At least Dr. Kuldeep, you should get into that. Yeah.
Yes, sir. Yes, sir. Sure.
Anand is fairly old hat in the sense you've been 10 years at Ramchandran. So you obviously are a high volume guy in terms of radial. So you mentioned 99% radial PCI for primary PCI. What about Dr. Rajaram? What is your lab?
Yes, sir.
PCI,
We
primary
always,
PCI. Primary
we always
PCI
99% only radial, sir.
only
Unless,
radial. Yeah.
yeah, unless it is very large bore is required more than 8 French and all those things.
That's a
Then
good
only we
message
go
to
for
give.
the femoral. Otherwise, no, only radial. Either if
So what
not
is
right
class
radial, it
one
is
in the
left radial also. We will go for it.
so what is class one in the Western world is class one with you both guys. Yeah. What about Kuldeep? Primary PCI access is radial always, or is it
Most of the time it is radial only, sir.
okay?
Only if suppose we are not able to get it in 1 or 2 attempts, then obviously we go ahead with femoral. Or suppose doing angio, there was anomalous subclavian or there is tortuous vessel, then we will, rather than wasting time in engaging the coronaries, we go with femoral.
So I was just pointing out that where you would prefer radial, where you would not prefer radial is one case that Dr. Sadanand showed.
Yes,
Yet
sir.
in a shock state, I would not go
Yeah, in
there.
a shock state, we would have gone
You
initially
did go
time. We
because
would
you're a
have,
99.9% guy, so it's fine with you. But otherwise, that's one area. The other area is a post CABG status patient. And has come with a STEMI, so then we would, with an any ACS, then we would almost always go femoral. These are the two absolute indications to go femoral and not radial in an ACS situation, at least in my lab. Yeah. So, Doctor, the other two winning moderators, you want to add some word? Otherwise, we can wind up. I suppose we are past
Yeah.
10 minutes past what we have done. So, we've had for the audience, we've had a very excellent discussion. First, Dr. Rajaram and Dr. Vidyut Jain and Dr. Rajaram, could you add some teaching points, what we got out of here? And then I can just
I think
wind it up.
well covered topic. No.
Well, almost well covered, sir. This is a common topic. In fact, the left main in acute MI situations is very intriguing situation. So sometimes what to do, what not to do, and all those things, that is important. So I think in acute MI situations particularly, you should simplify the procedures. So if you simplify the procedure, then you are safe. Most of the times, patient is also safe. So I think like our first presenter, nicely done. Simple thrombus, he has tried it. After that, simply has gone for the provisional stenting and then came out. So that should be the procedure in acute MI situations. It is not like the elective cases and all those things. So I think that point should go into the viewers, sir.
Yes, that's a very good point you make that in an acute MI situation, the clock is ticking and every minute matters as far as you save lives, more lives you save, the earlier you do. That is the thing that should always be there. Otherwise, you can take your time, do retrograde, do antigrade, whatever you want to. But in an acute MI situation, you have to come out with an open artery with a TIMI3 flow. That's what you are aiming for, and that should not be lost. And that's where primary PCI scores over lytics, yeah. And the ego should not come in the way to crossover, because the crossovers, even in these trials from radial to this, meaning all the ACS trials also, has been close to 5 to 10% crossovers, that way. So, but our scenario also, we should be willing to cross, and you should keep your time limits. Time limits, I suppose there is nothing there on the trial basis, but otherwise, recommendation wise, I would at least recommend not more than 5 minutes on a radial artery access or otherwise, and then simply go ahead, do the femoral and give him the perfusion first. That is what is the thing. And on that basis, we can, I think, wind up excellent. Both the speakers deserve a big round of applause. Though there is nobody to tell the applause, but we'll give you a big round of applause.
thank you,
Both
sir.
of you,
Thank you so much.
awesome job, and really it was a very interesting discussion with good points coming in from Dr. Vidyut Jain and Dr. Rajaram. And I will hand over to you, Dr. Dabade, to give the vote of thanks. Thank you, guys.
Yeah, I want to say a vote of thanks. So it's always we see you in big screens, sir. So now the election people have provided us opportunity to interact with you directly, like stalwarts like you, Dr. Rajaram or Vidyut, sir. So it's a good opportunity for us to interact with the giants. So I thank really the election people who provided us this opportunity. I thank all the seniors and teachers who added a lot of learning points to us. Thank you. Really, I learned a lot today. Thank you.
Thank you. Go ahead, Dr. Dabade.
Those kind words from Dr. Sadanandam actually means a lot to us. As rightly pointed out by our course director in the beginning only, this is actually the legacy program. We started this program almost in COVID era. We started with this, and it was liked by across India. When we used to have even with Dr. Hiremat sir, and then we forwarded with Dr. Kerkar sir. So yeah, those interesting and insightful cases always we feel adds to the knowledge and expertise for all those audience who are actually the cardiologists are listening to us, and that will definitely help them. There were few questions in the chat box, but I feel been already covered during our extensive discussion part. So I think it's needless to go back and take the questions. So with permission from our course director, Kerkar sir, we would like to conclude this session. But before the conclusion, let me officially show my deepest gratitude once again to our esteemed course director, Professor Dr. Profula Kerkar sir, for nicely directing throughout this webinar and taking the program in a very successful way. We also thank our both the moderators, Dr. Rajaram sir and Dr. Vidhu Jain sir, again to contribute into the discussion and to take the discussion at the next level. Now, then our sincere thank to both our speakers, Dr. Kuldeep Potawar sir and Dr. Sadanandam sir, to present in front of us the very interesting and insightful cases. And definitely, as I mentioned, it is going to help our audience across India during their day-to-day practices. Last but not least, I thank on behalf of Emcure to all the delegates who joined with us across India. And from our internal team to all the sales, marketing, and the medical team who contributed to make this program successful and cheerful. So, with that note, I would like to thank once again to all of you and a very good night and good time ahead. Thank you. Let's meet in the next meeting with
Bye-bye.
next topics.
Bye.
Thank you.
Thank you, sir. Thank you. Thank
Bye.
you all. Bye bye.